Welcome to Healthcare IT Today. I'm John Lynn, together with my colleague and friend Colin Hung. The world of technology and healthcare, ever changing in new and novel ways, and that's why we love this stuff. So join us as we discuss the latest healthcare and health IT news meshed together in new ways which help generate ideas and new perspectives. Plus, we'll have a little fun along the way. Today, we're going to be discussing the ironic and maybe funny contradictions in healthcare. And be sure to follow the show on social media at the hashtag HITSM and our personal accounts at TechGuy and at Colin_Hung. Plus, check out our 19 years of health IT content at healthcareittoday.com. Healthcare has contradictions.
I know, breaking news, right, John?
You're like, yeah, well, what's funny is people that aren't in healthcare don't realize it. Like, you have to be kind of a healthcare insider to realize, man, there's a lot of stuff that's like confusing, doesn't make sense until you understand like all the infrastructure behind it and the history. And then it's like, oh, it kind of makes sense, at least why it happened.
Yes. I mean, it wouldn't be healthcare if there weren't contradictions. I'm sure they exist in other industries too, but they are kind of funny. I mean, you have to kind of laugh at some of them that we have in healthcare, otherwise you'd cry.
What's
So,
interesting is I think you and I both love irony and even contradictions to some degree because like here's one that this is a more on the people pitching us for the conference that's coming up, and they here's the irony I posted about that, just to kind of totally tangential, but they sent me a pitch, right, and I replied and said, hey, we're doing our sponsor, then we'll get back for editorial, and then they do a follow-up email. The irony is, if you do a follow-up email, that means you're last on my list to follow up with. So your follow-up actually puts you at the bottom of the list, not the top of the list. And I don't know if they realize that. And I really love the irony of it.
that is very ironic, John. Well, okay, let's get to these contradictions. And first of all, this is a credit to some of the folks in the recent conferences because we've been talking about this, and this is what spurred the idea for this episode. But let me start by asking you this, or posing you this contradiction, John. You know, we all say, or it's been said, we want more personalized care, and yet almost every organization we talk to is rushing to implement more things like chatbots to remove people from the loop of healthcare. I find that ironic. What do you think, John?
I get the irony, right? Like, you're like, hey, let's make it more personal. Let's throw more technology at it. Like, on face, that feels really bad, right? Like, that's not more personal. But there's actually two reasons why it actually is a really good thing. The first one might be personal preference, so it may not apply to everyone. But to me, I often would rather interact with a chatbot than actually call in. So to me, that is a personalized service because I know the chatbot's going to do a very predictable, reliable thing, and it will do it instantly. I don't have to wait for it, and I don't have to talk to someone, which I don't really want to do. And often in situations where I can't talk because I'm in a situation where I don't want to call because I need to be quiet or whatever it might be, right? And so for me, the chatbot and that digital interaction is actually more personalized to what I want. And I think that's true for a lot of people, right? If you're at work, you can't call in to schedule an appointment for your doctor's office because you're busy working, but you could pull up a web browser and and do it real quick, right? In between, breaks or whatever it was, right? So anyways, I think that's the first part. The second part, which is something we've heard a lot, this isn't a new idea, which is that if we implement technology the right way, like a chatbot or other solution, then it frees up the humans to do the things that a chatbot can't do. And so it does actually allow for more personalized care because now the phone systems aren't overwhelmed with people calling with mundane things that a chatbot can do. It's only those people that are calling with more complex situations that need a human to actually address it.
Yeah, I like what you're saying, John, and I actually think that this contradiction is a good one as well. I don't see this as a bad contradiction. The irony is funny, right? That we are using technology, especially AI technology, to actually humanize healthcare, right? Like we've heard it many times before that the notes that sometimes the AI is able to generate and communications that AI is able to generate back to patients is actually more personable than the human generated content that goes back to patients. I find that funny. And to your point, I think when the technology is implemented correctly on the front end, where the chatbot can do the simple things like the setting the appointment or answering a quick question, I think that is a good thing because you are going to get more personal, more quick care the way you want it, even though it's not with a human being. But where I've seen it go off the rails, of course, is where you then hide your phone number, right? Like, well, then the only way is supposedly through this, interface. But those interfaces break down very quickly when things get complicated. Like when someone has to have four interdependent back to back to back appointments with different departments or with different specialists, that's not easy to do through a chatbot, right?
Yeah.
And you can get very frustrated very quickly, whereas you could resolve it very quickly by talking to someone. So you have to make it still easy for people to reach you, even though I know you want to kind of push everyone towards the technology. So
That's interesting. Your point's a really good one as far as like being able to personalize it and be able to give them, the opportunity that's powerful. There's two things. One is, I heard a story about an organization that was using AI to kind of filter up the important information from the notes. And there was a patient that had been a long-term patient of the hospital, the health system that they were visiting, and something came up in the third one. I think it was a chronic condition or something, and they'd forgotten about it because they were dealing with the acute need, whatever was happening. Well, the AI ended up surfacing and resurfacing that small mention from the third visit, and they're now on day 12, right? That the doctor had forgotten about, and it's like, oh, that's right, we need to address this as well. And so, like, that was a great example of the technology actually helping the doctor to provide that more personalized care that was needed. So I think that's, something that's really powerful as well.
I love it. Let's get to the next one, John, because I know this one's more up your alley.
Oh yeah.
Now, we have said for decades that we want more data interoperability and we want the easy ability to share data in healthcare. And yet we have more data silos than ever, right? We generate more data than ever. We can't share most of it. Will this ever be solved, John? And what do you think about this contradiction?
Yeah, I mean, longtime listeners will know some of how I feel that, like, I actually think that full longitudinal health record interoperability is a pipe dream. But, let's set that aside, right? Like, it's true. We want more interoperability, but the only question you need to ask yourself is who's we? Who's the we that wants more interoperability? Patients do. In fact, we just assume that it's happening. We want it to happen and just think that doctors share. But, those of us inside don't, right? So, and then here's the other problem is that as startup organizations and even provider organizations, data is power. Data can be monetized, it can be leveraged, it can be used, to power your organization, to differentiate your organization. And so there is this competing contradiction that says, hey, we need to share this because it's the right thing to do for the patient and it's going to improve the care. And in a value-based care world, you get paid more, and that's great. And we need to do that, right? But there is this competing thing that says, if I hold the data, then I hold the power to it. And so, I think it's going to be interesting to see how that plays out. And we see it playing out in a lot of different ways that are good, bad, and otherwise. There's one, I mean, look at the example of our friends at Qualtrics that acquired Press Ganey. They weren't acquiring the business as much as they were acquiring the data that business holds, because they know we can change the patient experience with all of that patient experience data. So, I mean, to me, that's the illustration of the power that's available in that data and the value that's in there. And so, I actually think we're going to have this challenge forever, which is we want to share because it has value to the patient, but there are contradictions of why you want to keep the data to yourself.
Yeah, I'm with you on this one. It's a bad contradiction, right? We do have misaligned incentives where holding on to data, especially as I'll call it a vendor or a service provider, because you're right, data is power. If I'm holding the data, if I'm able to glean a little bit more insight than you are from it, or I'm able to provide back some insight that's only available through the data I collect, that is valuable to me. And so why would I give that away for free, or why would that make that freely available? It's not in their best interest, in other words. So it is unfortunately that push and pull, and I'm not sure the financial penalties is going to solve this, right? That we have and the enforcement that we have. I think it'll help, but I just think that I think we have to give up on the general interoperability dream, like that you're saying. I think we need to establish a more narrow framework to say this kind of data we want to share. This kind of
Yeah.
data, we just don't have to worry about that. Like we're just not going to bother trying to address that right now. But let's go after the most important stuff that needs to be shared. And let's define what that is, not necessarily the whole thing. Because I
Yeah.
think that's what's blocking us from actually achieving any meaningful interoperability.
Yeah, I think that makes sense, right? Like point to point data sharing, it's already happening in a lot of different situations and it's solving a lot of problems and improving care. And I think that's going to continue to expand and grow. I mean, your question's an interesting one. Why would I share? And the only answer now, not maybe not the only, but the strongest answer now is information blocking. Like how that plays out is actually a pretty strong incentive. So I would say it's stronger than what you described, as far as, convincing them to just because they have to, not because they want to, but, there's going to be some significant legal ramifications if they don't with information blocking. So I actually think that does open up a lot of sources. Is it going to open up everything? No. So to your point, we need the specific use cases. But information blocking is causing changes in behavior when it comes to sharing.
Yeah, it is ironic, right? That it took a penalty in order to really, really motivate people. Whereas the good of the collective, which is kind of what healthcare is about, right? Like treating people, helping people. We couldn't find a way to do it on our own, right? For the good of the community. We had to wait for the stick, in other words, to make it happen. That irony I do find funny. But you're right. I mean, I think it will help. It'll be interesting to see how this plays out over the next few years. But we do finally have something where people go, oh, okay, you know what? That's a pretty big penalty. Probably don't want to have that. Let's go ahead and start working on making our stuff a little bit more interoperable. So hopefully
Well,
that
I think the incentive would have worked too. If meaningful use would have been focused around sharing data rather than some other things, it would have changed things as well. In fact, many people are calling for that. They're saying, okay, the stick's great and it's motivating some change, but like we need incentives to really change it.
Well, let's hope those come out. That'd be a whole other episode, John.
You never know if the economy tanks, maybe there'll be another stimulus and they'll do interoperability.
There you go.
Not
There you
sure
go.
we
One,
want the economy to tank for that though.
yeah, exactly. Let's not hope for the former in order to get the latter, right? Let's
Yep.
hey, if you're just tuning in, you're listening to Healthcare IT Today with John Lynn and Colin Hung. Today, we're talking about the ironic contradictions in healthcare. All right, John, this one's a fun one I've got here for you. We say that there is a shortage of clinicians. We're already in it. It's going to get worse over the next few years. Yet, on the other side, we in healthcare hesitate to adopt innovative technologies that streamline care delivery. Talk to me about that.
Yeah, I mean the shortage is interesting, and the shortage in many ways is a problem because it takes so long to create that, for lack of a better term, natural resource, right? Like, you have to be, medical school takes a long time. I did hear one organization who said, well, the nursing shortage isn't any worse than it's always been. So I thought that was an interesting take too, which I was like, so we're just chronically understaffed. So that's just the reality. I don't know. That doesn't sound like a good solution either. But you're right. I mean, there is this irony between, okay, we could implement this technology that would mean we need fewer staff. That scares some people. Even just me saying that phrase right there, like, oh, fewer staff. Does that mean we're going to lose our job? Right? Like they write that whereas the right way to look at it is, hey, we need this technology so we can work with fewer staff because we only have fewer staff, right? Like that's just the reality of what we're working with. So it is interesting, but to be fair, the problem here and the reason this irony exists is because it takes true leadership to be able to implement this. Why does it take true leadership? It's because there's a risk. There's a risk involved that if I implement the technology, it's actually not going to improve my staffing situation. It's not going to make us more efficient. And there's a lot of people to blame for that. Probably the EHR being the first one to blame for that because we implemented it and it didn't reduce staff. It actually increased the cognitive burden on people because we said, because we didn't just say, let's implement a technology to reduce burden. We implemented it and said, oh, now we can ask you a bunch of other things that we didn't ask you before. And so when we implemented the HR, it didn't improve it. And so, I think there's a lot of people that are burnt and afraid because of that experience that now they say, well, if I implement this technology, they don't believe it will actually save them the staff. And so I think that's a risk that organizations have to take. And the other part of that risk is that as a leader, you have to invest something ahead of time hoping that you'll have the downstream benefit. And so that's why I say it takes true leadership to be able to paint that picture and say, let's spend now so that later we can benefit.
Uh, Hard to contradict you there, John. I I look at this problem the same way. I mean, we have a shortage, and yet healthcare itself is inherently risk averse, right? And so we're naturally skeptical when new technologies come in claiming to do what they say they do. Now, I think actually that is healthy. That's We shouldn't take everything at face value because
Sure.
what works in the petri dish, what works in the positive use case doesn't work in all cases.
And we should
Um,
hold them accountable for it, right?
right.
Which they don't always do.
But I think we do kind of go a little bit overboard, right? Where
Mm.
we, either will pilot something to death, take 3 years to test it before we actually, believe it. And in the meantime, the problem just gets worse and worse and worse. So I do think we need to be a little bit more open-minded to some innovative technologies. I still think we should pilot them, but really put the effort in to pilot it right, to really discover where it does work and where it doesn't. And then not to say wait for everything to be in there. Okay, well, we found out it works in A but not in B. Well, maybe we should implement it for A, right? Let's get it in there now. Let's not wait for A and B because I think that is a tendency for people to say, okay, well, we tried it. We've identified these 10 issues. Go fix them and then I'll implement it. Well, that's going to take some time and sometimes could be years. And
Mhm.
so I look at this as a funny irony to say, well, why are we waiting for that perfection? Right? Like
Mhm.
let's implement it now. Let's start solving the problem now rather than waiting for this magic bullet that or the magic pill that's going to appear a few years down the road.
Yeah. I mean, the reality is this: a pilot without a pathway to production is just wishful thinking and it's a waste of time. And so, like, to your point, like, if you're just piloting it without some sort of way to say, hey, if this is effective, this is how we're going to implement it. Then that's poor leadership in my view, right? And I'm saying leadership in the broadest sense because we know that in healthcare, it's not one leader that can drive it forward. It's a leadership group or committee that needs to get behind it to actually do it. So, I think that's one of the challenges. But the reality is this that technology is going to be the solution to this staffing shortage, the shortage of clinicians. Like we aren't going to create more clinicians. And so the only question is, are you going to embrace it or not? And here's the challenge. Some leaders have led with, let's just throw more people at it. And that was how they went to solve everything. Oh, we need to do value based care. Let's hire some case managers. Let's throw more people at it. Let's have more people calling patients. Oh, we need to do release of information. Let's throw some more people at it. They can all pull the information to do the releases, right? Like that was their mindset. And that can work. Humans are incredible. They're very malleable and can do all sorts of things, right? That's what's nice when you invest in a person, but that isn't going to scale to the problem. That's the challenge.
I will challenge you one thing, John. I think there is a way we can mint more clinicians.
Oh yeah.
Uh, but and that is there is some talk, certainly up in here in Canada, there has been some talk about actually shrinking the teaching time to mint a new clinician. So instead of 7 years, like what we have is a new innovative family practice school. Like, so it's just
Okay.
minting family practice physicians, and that's only a 4-year program instead of a
Interesting.
7-year. Because they go, well, why do they need to go to a hospital rotation? They're not going to be in the hospital, right? They're a family physician. So let's
Mhm.
remove all that stuff. So they're actually creating a curriculum that's purpose built for that one specialty. And hopefully
That's
that can be a
creative.
model. Yeah.
Well,
To
and
think
they're just going to use ChatGPT anyway.
no,
Let's just
well, that's a whole other thing, John.
That's another episode.
All right, last contradiction here. And this is a pet peeve of mine. You know, we say we are supposed to be patient-centered in healthcare, yet there are hardly any patients involved in the design of health IT solutions. How do you wrap your mind around this one, John?
I think you should start. This is your pet peeve. Let's hear your thoughts, and then I'll I'll
Okay.
add to it.
Okay. So this one is a bad contradiction for me because yeah, we say this all the time. We've been saying it actually for years, and a lot of vendors actually say that they are designing to be for patients, right? And they're trying to help them and help their. And yet, when you ask them, okay, well, who did you get involved to, like, how did you get patient feedback on this? And
Mm,
there's no really good answer, right? So I I look at this and go, we need to pick this up. Like it doesn't sit well with me that we say we're patient centered and yet we don't get these people involved, right? We need to. I'm not talking about like a full on focus group or something like that, but have a representative patient, a real patient with chronic condition, someone with lived experience, have them give input like you would a doctor or a nurse into the design phase of your solution. And I'm not looking just at vendors. I'm talking about providers as well. If you're designing and going to roll out a portal, get some patients involved to give you some feedback of how that portal functions or doesn't function. Maybe you can streamline something by adding a little widget here or there. Get that feedback in order to truly make that difference. And your implementation will go much smoother. You won't have to go back and rework something. That's the irony for me, is that if you'd asked patients ahead of time, you probably would have saved yourself a lot of extra coding and a lot of heartache to go back and fix something that should never have been broken in the first place.
yeah. I mean, I hear what you're saying, and I understand it, right? You need, and the big challenge for most organizations, the patient is not their customer. They're not the one paying for it. That's why they probably don't listen to patients the way they should. And there's downstream impact to that when they don't, right? And when the people that they are their customer don't know the patient well, then they suffer, right? Now, sometimes the people do know the patient well and they create good products. So, that it's not exclusively. You can create a great product for a patient without talking to them. But like you said, it's great to talk with patients, and I'm probably going to piss off some of my friends like Jen Hoare and Jeff at Savvy Co-op and stuff, but it's like, and actually, I think she understands this as well. Asking patients is great if you ask the right patients. In fact, I think we did an episode of this 100 episodes ago. Asking doctors is great if you ask the right doctors. The same is true with patients. Like some patients, you can ask them something and they actually can't abstract the experience beyond their own experience. And that becomes problematic. Now, you could say that's the product manager's job, is to talk to enough patients so that then they can abstract it across, all the different types of patients that are using the product. And to be fair, that's true as well. And there's some really bad product managers that aren't good at doing that. So I'll acknowledge that. But here's the problem: you talk to one patient, if they're a chronic patient, they're not going to represent me because I'm not a chronic patient, right? And so if you build the experience for the chronic patient, well, then you might be creating a really awful experience for me. Like, why are you asking me 100 questions when you should only ask me the 3 that apply to me, because that's all that applies. Whereas with the chronic patient, you do need the 100 questions, and we could probably dive into usability. Like, you shouldn't ask them 100 questions either. You should pull that 100 questions from some other source of data, but you get the idea, right? Like their need is very different than my need. And so that is the challenge, I think, asking the right patients who will give you the right perspective that can be abstracted across the population that you have to do. So I think that's the thing patients maybe don't understand. And there certainly are egregious examples that someone should bring up in social media to about, in response to me saying this, there it's like, well, this is obvious. They should have understood that. And I'll be like, yes, you're right. They should have understood that. But you have to realize there's 10 other things they were working on and dealing with that they probably didn't realize, your egregious example, so I guess that's my only challenge with this whole ask patients is you have to either ask enough patients or you need the right patients who can abstract it across the whole population of what's really needed.
Well, I think the key here is that you can't design a product with an N of one. I mean, that's just bad. That's just bad design, right? Like if you're basing your entire product on your own experience, good for you, but you're really solving your own problem, right? You may solve it for 10 other people, but you probably won't solve it for 1,000 or 10,000 or a million. You need to get a representative number. And if you can find patients that can represent others, great, you win, right? You don't need as many. But I think what you just raised there is the important point. You need to get as many of those voices as you can to really truly design a product that's really going to hit the mark for everybody. You need to interview a lot of patients, a lot of physicians, nurses, get that input so you can make your product truly well designed. And it shows. I mean, it is very easy when you put these products in front of the right, the user, when you have done your homework and really designed it properly for them. People notice that difference.
Yeah, or the common one in a startup. It's not N of one, it's N of 10 because there's 10 at the startup. But then you realize that they're mostly affluent white males that, that are relatively healthy. It's like, wait, okay, well, you have an N of 10, but your 10 are all ubiquitous. So that's not good either, right? And they're like, well, we'll ask our friends. We're like, well, sorry, they're affluent males, female.
Yeah.
Maybe there's some gender there, but like, it's like that's different than someone who lives in a less affluent area that's not as connected, that doesn't have the same transportation. I mean, that was the complaint of the Apple Watch, right? Well, who buys that? Not, it was that higher level tech population that's very savvy, that doesn't spread to the entire population. So yeah,
Right.
that's 100% it.
I think the bottom line is, John, there's a lot of contradictions in healthcare and therefore a lot of opportunity in
And
healthcare, right?
maybe a future episode or two or three, five.
That's very, very true. Hey, but hey, thanks to all of you who tuned into this episode of Healthcare IT Today. For more details about our show, please check out the programs page on healthcarenowradio.com. And please share your voice and engage with the community at healthcareittoday.com and on social media using the hashtag HITSM. I'm Colin Hung, along with my friend and Health IT collaborator, John Lynn. Thanks for listening and have a great week.